So this is the Muscular System Lab. We're on page 20 in the lab packet and going through page 21. So lots of different muscles that you need to know for this lab. One other additional thing you need to know is the action of the muscle. So not only the name of the muscle, but also what it does, what it causes, flexion, extension, or whatever. We'll get into that when we get to those specific muscles. So the first part of your lab packet on page 20 differentiates between the three different types of muscle tissue microscopically. So this PowerPoint slide here is from your textbook, and it identifies the different characteristics of each muscle tissue type. So if you start with skeletal muscles, you've seen this before, right? This has been on your previous lab exams in terms of different tissue types you had to know, and this is skeletal muscle. So this is the muscle that's under voluntary control. It's attached to bones, and key characteristics that distinguishes skeletal muscle from the other two types of muscle are these striations. That's one characteristic of skeletal muscle, and multiple nuclei. So if you look at a single skeletal muscle cell that's shown here underneath, it's a long cylindrical cell with multiple nuclei. And so when you look at it, it's just kind of rows and rows of skeletal muscle cells with multiple nuclei, and these vertical stripes are what we call striations. If we compare that to cardiac muscle, so this is the muscle that makes up the walls of the heart, very similar in the sense that there's striations, but you're going to see these unique dark structures. These are not nuclei. These are special structures unique to heart muscle, and they're called intercalated discs. And you don't need to know that term yet. We're going to have you accountable for that term when we study the cardiovascular system. But you'll just see that that's a unique feature of cardiac muscle tissue. And you'll notice that there's not as many nuclei per cell in cardiac muscle tissue. There's one nucleus per cell, but they are branched. And this one looks like it has two nuclei per cell, but much fewer nuclei per cell in cardiac muscle tissue, and they are branched. So we can see they're not just made up of one single cell, all bundled together. They're branched. So we're going to see some, not uniformity like we see in skeletal muscle tissue. We'll see there's some spaces in there between those branched cells. But they are striated. And we'll talk about what makes up those striations in a little bit. And then we have smooth muscle tissue. And smooth muscle tissue are, kind of flattened cells that are tapered on the end. Some people describe them as being spindle-shaped. But they have a single nucleus, and they are, mostly laid down in sheets or layers. They form the walls of hollow organs, and they're also found in our blood vessels. So that's smooth muscle. No striations, just sheets of these spindle-shaped muscle cells. So on a lab exam, you would expect to see, a picture of these different tissue types, and you'd have to identify what type of muscle it is. You don't have to know any of the parts, though. Just be able to distinguish between the three different muscle types. And then if we look at a typical muscle cell, we see a couple of different unique structures. So this is one muscle cell. So this would have to be the plasma membrane, right? That outer covering. The special name for the plasma membrane of a muscle cell is called a sarcolemma. So sarcolemma is just a fancy name for the plasma membrane of a muscle cell. The sarcoplasm is the cytoplasm of a muscle cell. So the fluid inside, underneath this plasma membrane, is called the sarcoplasm. And then we can see there's multiple nuclei. That's what these purple structures are, the multiple nuclei of this muscle cell. And then there's these little straw-like cylindrical structures that are found inside the muscle cell, and these are called myofibrils. Myofibrils. So they're small little contracting units inside of the muscle cells. That is where all the action happens when you talk about muscle contraction. So it's these myofibrils inside. And the myofibrils, so if I look at one of these myofibrils, they're made up of myofilaments, which are even tinier thread-like structures made of protein. And that's what these lines are forming here. You see these horizontal lines. Those are myofilaments. So if we zero in on one of these myofibrils, looking a little closer, these horizontal lines are the myofilaments. The thicker ones are called myosin, and the thinner ones, so the thick red horizontal lines, are called myosin, and the thin blue lines are called actin. So actin, thin, think of it that way. But all you need to know is myofilament. So if Deke had the pointer right where this pointer is, the answer you would need to put would be myofilament. That's sufficient for lab. In lecture, we'll talk about actin and myosin. You'll have to know those details. But for now, it's just myofilament. And then sarcomere is a portion of a myofibril from this kind of zigzag line here to this zigzag line. These are each called Z-discs. This zigzagged line and this one here, those are called Z-discs, each individual one. We'll talk about that more in lecture, so you'll understand that better, you know, after lecture on our next lecture. But regardless, the distance from here to here is called a sarcomere. So it's a contracting unit of a myofibril. It's the portion of the myofibril that actually shortens during contraction. And we'll get into that whole process, like I said, in the lecture part of the class. So if we zero in on a muscle cell and we look at the motor neuron that stimulates it, so that's what's shown in this picture here. Zoom in a little bit. So here's this is the myelin, the blue, here's the axon, and here's the axon terminals that end on a muscle cell. So see that there's more than one axon terminal that synapses or stimulates one single muscle cell. So if we zero in on this relationship between one axon terminal of the motor neuron and the muscle cell membrane, that's what's shown here. So this is basically taking this little relationship between the axon terminal and the muscle cell and blowing it up to look at more detail. So this relationship between the motor neuron and the muscle cell membrane is called the neuromuscular junction. So in objective number 3, you'll see in the title there, it says identify the following pertaining to a neuromuscular junction. So that's just a junction is where two things come together to join. So we're looking at the muscle cell membrane and the motor neuron. So the motor neuron again is in yellow and the muscle cell membrane is in gray. So notice they're not in direct contact, there's a space between there. So this space here between this membrane of the motor neuron, axon terminal, and the muscle cell membrane, this space is called the synaptic cleft. Another name for it, no, actually, that's it. We'll just keep it with that. So that's the synaptic cleft. And then the axon terminal, again, is this yellow structure here. And the actual membrane we call the presynaptic terminal. Pre, it's because it's before the synaptic cleft. And then the postsynaptic terminal is the muscle cell membrane. But another name for that, for the muscle cell membrane, is the motor end plate. Motor end plate. Because what we're going to find is these pink arrows represent an action potential coming down the motor neuron to the axon terminal and stimulating the release of a neurotransmitter, which is called acetylcholine, which is going to diffuse out into the synaptic cleft and bind to these ligand-gated sodium channels. And what happens when a neurotransmitter binds to a ligand-gated channel? What does a channel do? What? It opens up. And we know that there's always more sodium outside cells than inside cells. So there's sodium floating around in this synaptic cleft outside these cells. And if we open up a door, sodium goes rushing in. So sodium is going to rush into this muscle cell. And what's going to happen as it depolarizes is it's going to reach threshold at -55, right? And then it's going to fire off an action potential. And we'll get an action potential in this muscle membrane that'll travel down the membrane and off to the muscle cell, down deep into it, and it's going to stimulate these myofibrils to contract. So the only way our muscles can contract is if they receive an impulse from a motor neuron that stimulates it. So this is the synaptic cleft, this is the motor end plate on the muscle cell, and the axon terminal. So that relationship we call the neuro, which is the axon terminal, muscular, which is the sarcolemma, junction, where they come together. So if we zero in on a cross-section of muscle, so here's a whole muscle now. This is not a muscle cell. This is a whole muscle like a beef roast you buy at the grocery store. If you look at that roast, you're going to see there's a shiny connective tissue outer wrapping on that roast, and that's called epimysium. So epimysium is always the outermost layer. So you're going to learn about the epicardium. That's the outermost layer. So the epimysium wraps around the muscle, and then as those muscle fibers end, we have just epimysium here. And if it's in a thick band-like structure, we call it a tendon. So this is a tendon here. It attaches muscle to bone. It's made up of epimysium. And what do we know about the type of tissue that makes up epimysium? Tendons and ligaments. You remember the muscle tissue type that's tendons and ligaments? Yeah, dense, regular, collagenous. Another name for it was fibrous, right? Yeah, so that's the tissue type found here, but you don't have to know that for this lab. So anyway, so this is called a tendon. Now, let's see. If we look at these individual muscle cells here, so here's muscle cells inside of this bundle, which is called a fascicle. You don't need to know fascicle. But this bundle of muscle cells are separated from each other with an inner connective tissue, which is called endomysium. So that's what's shown here is endomysium between the muscle cells. And the white, that would just be the plasma membrane, right? That would be sarcolemma. But the tissue between there, between those muscle cells, is endomysium. So we have another type of epimysium in a flattened sheet arrangement. We call that an AVO Neurosis. So that's what this is an AVO Neurosis. So instead of that epimysium being in a thick band-like structure, like in a tendon, it's in a flattened sheet. And it gives a white glistening appearance, you know, in a fresh dissection. So this is called an AVO Neurosis. Same thing, it's dense, regular, collagenous. It's a connective tissue outer covering called an AVO Neurosis. So if you look at the models with the skulls, you can see that white connective sheet. We also see an AVO Neurosis over the abdomen. And if you turn look at a model from the backside, there's an AVO Neurosis in the lumbar region. So it's just these flattened areas of connective tissue. All right, so if we look at these muscle models here, this is one of the models we have in class. So this is a muscle cell. You can see the nucleus underneath the plasma membrane. So this outer covering here is plasma membrane. And what would this be here then, this connective tissue outside the plasma membrane? It's one of the two that we just talked about in objective number 4. It's either endomysium or epimysium. Epimysium covers the whole muscle. So if we look at the picture here, this is a whole muscle made up of, so it's this connective tissue. So right now what we're zeroing in on in this muscle model is one single muscle cell. So we're looking right here at this. So the connective tissue wrapping outside, here's the plasma membrane. So outside of that, in between here is endomysium. Yep, endomysium. So this here is endomysium. What is this structure here then that's on the outside of this muscle cell? What part is the stimulating part of a neuron? If we go back to our picture here, what is this? Yeah, axon terminal. So if we go back to this, here's the motor neuron coming in, and here's the axon terminals. So this is an axon terminal, and then what is this part of the muscle cell membrane here where that axon terminal communicates? What is the white? We can look at it in cross-section view here. You can see the myofibrils of the muscle cell membrane. So what is this white? Yeah, the motor end plate. Good. So that's the motor end plate. Here's the axon terminal muscle cell membrane, or axon terminal neuron, or nerve cell membrane. And what is the space in between here called? Yes, the synaptic cleft, good. So this whole relationship here is the, what do we call this whole combination of these two structures, the neuron and the muscle cell?
Neuromuscular junction.
Very good, neuromuscular junction. All right, here's another model we have. Here's the numbers that you need to know, 1, 3, 4, 13, and 14. So number 1 is pointing to what? Take a look at what you have here. Here's the motor neuron coming down. Here's the axon terminal interacting with this portion. So what would number 1 be? The motor neuron stimulates one muscle cell. So this is a cylindrical structure inside the muscle cell. Do you remember what those were called?
Myofibril.
Yeah, myofibril. Think of little fibers. Muscle fibers are whole muscle cells. Fibers within a fiber we call myofibrils. Just think of it as like little fibers. So that's a myofibril. And then number 3 is pointing to this beige membrane here. So it's pointing to this. What would number 3 be pointing to? It's on the muscle cell.
The Epimysium.
Well, that's a connective tissue wrapping outside the muscle cell. So endomysium would be this here. This is the muscle cell membrane. So if we follow that around, we see the muscle cell membrane. It's kind of indented here where the neuron communicates. So what do we call the muscle cell side of this relationship? Motor end plate, yes. And then number 4 would be number 4 is the membrane of the neuron. That's just the membrane. So the space between, I believe, is, let's see, 13 and 14. 13 and where's 14? Oh, okay. Well, yeah, I think for number 4, we could say it's either the motor neuron plasma membrane or the synaptic cleft if it's, we want to extend that line a little further into the space. So both of those. But the space, I mean, I guess technically like right here where it's a little gray, that would be the space between these two cells, and that would be the synaptic cleft. So what is number 14 then? And this is endomysium here. That's the connective tissue wrapping. But the covering of a muscle cell, we can see it kind of comes inward here. We'll talk about this structure, these little tunnels, but we'll talk about that later. But what do we call the plasma membrane of the muscle cell?
Sarcolemma.
Yep. So this is sarcolemma, this is sarcolemma. The motor end plate is sarcolemma, isn't it? We're being just a little more specific. It's the sarcolemma that's underneath the motor neuron. So we call it the motor end plate, that portion of the sarcolemma that's being stimulated by a neuron. So that's one and the same, sarcolemma, motor end plate. But you do need to call it motor end plate if it's right where the motor neuron is. So, and number 13, this is just what? What's the inside part before we get to the axon terminal? What do we call that yellow structure? Bundles of myelinated axons. So we're looking at the motor neuron, right? So this came from a nerve. So any nerve coming off the spinal cord, branches, right? And then one motor neuron and its different axon terminals. So this is the axon before it becomes terminals. So you do have a picture of that, or an actual model of this to look at and practice with. So be sure that you look at that. Okay, so then the next part is looking at all the parts of the muscular system itself. So we start with the head. We'll continue then on page 21, looking at all the different muscles. And again, remember, you have to know the action of these muscles, but the good part is it will be in a multiple choice format, so you'll have the actions to choose from, and you'll just have to recognize it, which makes it a little easier than pulling it out of thin air or memorizing it, you know, in addition to all these parts. So starting with the first one, occipital frontalis, that is a muscle of the forehead. So that's what's labeled number 1 here, is the occipital frontalis, which it covers the whole front of the head, but there is an AVO neurosis that covers it. But here the AVO neurosis has been removed so we can see this muscle. So that's the occipital frontalis. So when you elevate your eyebrows, you raise your eyebrows, that's the occipital frontalis that's contracting. So whenever you're thinking about how these muscles act, just remember when they contract is they're working. So they're getting shorter. So think of what they pull on as they get shorter. Just like your arm at the elbow bends when the biceps gets shorter. When the bicep relaxes and elongates again, it relaxes the arm and stretches the arm out. So just you have your body to bring to the lab exam and look at, okay, if I shorten that muscle, what does it do? So that kind of helps. So that's the occipital frontalis. And then the orbicularis oculi. Orbicularis is a round muscle that goes around a structure. So the orbicularis oculi, remember we talked about, well, maybe we didn't. Ocular lenses refers to the eyes. So this is the orbicularis, like things go in an orbit, planets orbit the sun. Orbicularis oris, oculi is around the eye. So the job of it is to close the eye. And then if we skip down one, the orbicularis oris is around the mouth, which we refer to as the oral cavity, right? So orbicularis oris goes around the mouth. So orbicularis oculi and orbicularis oris. And the orbicularis oris, its action is to pucker up the lips, like in giving, you know, your dog or grandma a kiss. That's the orbicularis oris. The zygomaticus is seen here on the side of the cheek. Remember the zygomatic bone? So that's the zygomaticus. There's 2 different kind of pieces to this muscle. It's shown here in number 3. You can see it best right here. Comes just down over that zygomatic bone. So the zygomaticus elevates and abducts the upper lip. So when you smile, that's the zygomaticus muscle that's working. So do you ever like laugh so much or have to smile for photos, for like a wedding, or seeing your pictures where your cheeks start to hurt, right? Because you're pulling, you know, you're contracting that muscle a lot. And some people that have natural smiles, you know, it's no problem when using that muscle. Other people that have more stoic expressions, you know, they have to work that muscle a little more to get a natural smile. And the best way to improve your natural smile is to smile a lot. You'll actually work that muscle and it'll be easier to smile the more you practice it. So in healthcare, I can't tell you how many times a smile can change a mood when you come in. You know, when you say, so should we go for a walk today? Versus, should we go for a walk today? Patients are more likely to be like, no, I'm in pain, leave me alone. So smiling makes a big difference in healthcare and anywhere for that matter. Okay, so then we have the masseter muscle. The masseter is a thicker muscle. It's just in front of the ear, and if you clench your teeth, this is number 5 in the model, if you clench your teeth, you can feel that bulge outward. So its job is to close your jaw. And it's also important in chewing. It's actually a really, really strong muscle for its size, one of the strongest muscles in the body for its size. So closes the jaw. And we can get a lot of stress in the masseter when we clench our teeth when we're stressed, or if you chew gum all day, you tend to get kind of a sore jaw, that muscle gets tired. And then the temporalis muscle is on the side of the head. That's number 6 here. And if we look at that, that too elevates the mandible or closes the jaw. So you might find if you've been chewing gum all day that you get kind of sore on the sides of your head, right? Or if you're holding a lot of stress, we tend to clench our teeth, you know, when we're stressed. Some people grind their teeth at night. They don't even know that they do that until they're told by someone who's sleeping near them. They can hear it. But a sign of that is waking up with a sore jaw or a headache, you know, particularly, you know, in the temples there. That's the temporalis muscle overworking with tooth grinding. So, and then over time you wear away the flat surfaces of your teeth. Some people have to wear a mouth guard at night if they're tooth grinding. So that elevates the jaw as well. That's the temporalis. And then we have this thick muscle that attaches on the back of the to the bone at the back of the ear and to the front of the sternum here. So number 7, we can see this thick muscle. It's on either side of the neck, here and here. Attaches back of the ear. Remember the mastoid process back there? So that's where it gets its name. It's the sternocleido, so it attaches at the bottom here. It attaches to the sternum and the clavicle. So sternocleido, cleido is referring to clavicle, and then mastoid bone. So it behind the ear to that mastoid process. So if it runs down both sides of the neck and we shorten one side, it's going to turn the head in the direction of that muscle that's shortening. So when we contract one of these muscles, it turns the head left or right. What does it do to the head if we contract both? Yep, brings your head down, flexes the neck. And we use the term flex whenever we're shortening the angle where two bones come together. So when we're putting our chin to our chest, we're shortening that angle, and that's called flexing. When you bend your elbow, bring your wrist towards your shoulder, that's flexing the elbow. The opposite of flexing is extension. So when we increase the angle at a joint, that's extension. So be sure you understand flexion versus extension, and you have to use those terms with these actions. You can't say straighten the arm. You have to say extend the arm. You can't say bend the knee. We have to say flex the knee. Okay, so that's the sternocleidomastoid muscle. And if I turn my head, you can see how it kind of sticks out. That's that muscle. Okay, then we move down to the arm. Get rid of that picture. So looking at the large muscle that is at the top of the shoulder, it's triangular shape, which in Greek is the letter delta. Looks like an upside down triangle. So we can see it's flat and broad here at the top, comes to a point here at the bottom where it attaches to the humerus. That's the deltoid, and it abducts the arm. And to abduct means you're moving the body part away from the midline. So if I put my arms out, straighten my arms out to the side and hold them out there, I would really get tired in my deltoid eventually, because that, is what shortens to pull the arm outward. So abduct, with the B, letter B as in boy, abduct means to move a body part away from the midline. Just like when a child is abducted, they're taken away from their parents, right? So abduct means away. Adduct means to bring it closer to the midline. So when I take my arms from being horizontal and I bring them down back to my thighs, that's adducting. And which one goes against gravity in that case? Abducting goes against gravity. So the deltoid is usually much stronger than muscles, and we look at the leg too and the hip. The muscles that abduct are usually stronger than the ones that adduct, right? Because to bring your legs back together is just dropping them together. So we're not working against gravity. So this is the deltoid. And in healthcare, what do we need to know about the shape and size of the deltoid for? Right now is the season for the intramuscular injections, vaccinations, right? You get your flu shot here, tetanus shot. All those injections go into the deltoid because it's a pretty decent muscle. But if you have a tiny, thin little old lady in a nursing home that doesn't abduct her arm hardly ever, she just sits in the wheelchair, and people are pushing her, so she's not even hardly using her arm muscles, that can be a pretty atrophied, thin muscle. So we have to be careful we don't go straight into the muscle and end up injecting that into the bone, because that can happen. So you need to plump up that muscle a little bit and make sure that there's some beef there to inject into, because there's other choices. Like babies, little tiny babies, what is their arms are not very developed yet, right? So we don't use vaccinations for babies there. Where do we go for babies? Where's a heftier muscle in a baby? What? In the thigh, yep. In the front of the thigh. So that's the deltoid. It abducts the arm. And then the trapezius is this diamond-shaped muscle. Now it's cut away on this side of the model, but it's a diamond-shaped muscle that comes down from the back of the head to the tip of the shoulder and down to the middle of the back. So it comes up like a diamond shape. And that's the trapezius. And the job of the trapezius is to extend the head. So when you raise your head to put your nose in the air, that's the trapezius that's shortening and pulling the head backward. It also moves the scapula. So when you shrug your shoulders, that's the trapezius that's working. Did you ever have to carry a heavy backpack and you get really sore, right, in the trapezius? Or if you're working at a computer and you're sitting there for a long time, or even studying for a test, right? You're writing and you've got your arms on the table, you can get really tight in this portion of the trapezius. And doesn't it feel wonderful for those that like massages to get a little massage on the upper portion of the trapezius, right, and over the shoulders? Makes a big difference in loosening up that muscle and reducing tension, headaches, and you can get pretty tight there. So it's a good idea to kind of just move your head around every now and then and kind of rotate it in a circle to loosen up that muscle. It tends to store a lot of stress. So then the latissimus dorsi is below the trapezius. Latissimus, think of it as lateral, latissimus. So it's this big sheet of muscle here on the lateral aspect of the posterior side of the body and on the back. So dorsi, like the dorsal fin on a shark, is what sticks out of the water. So latissimus dorsi. We also call these in the weight room, guys call them, and girls call them the lats, right? Those muscles right below the armpit there. If someone's a swimmer or they really have well-developed lats, they kind of walk around with their arms out to the side, right? So that's the latissimus dorsi when that's really well developed. So when people do the lat pull downs in the gym where you've got the bar and you pull it down behind your head, that's how they're developing the shoulder and the lats, or latissimus dorsi. So when we look at the action of it, adduct, you're bringing the arm closer to the midline. And it also extends the arm. So to extend the arm means I'm looking at the shoulder. I'm not extending the arm at the elbow, but I'm looking at the shoulder. So when you bring your arm back, like you're gonna throw a football, but if you keep the arm straight and put it back, that's extending the arm. So if you think about extending the arm and adducting, isn't that like the swimmer's stroke, like if someone's swimming the freestyle? And that's where if you look at a person like Michael Phelps, the big swimmer, he has really well-developed lats, doesn't he? Because of that constant motion of that power stroke is what we call that. When we bring the arm back and forward, as in swimming the freestyle, we call that power stroke. The pectoralis major, so now we're on the front side of the body. The pectoralis major is this large muscle over the chest called the pecs. It adducts and flexes the arm. So when we talk about flexing, we're talking about bringing the arms forward, like as if you're touching your elbows in front of your body, putting them together, that's flexing the arm. So when people do the pec machine at the gym, they're putting their arms in that, whatever, there's different types, but they're making this motion. So they're flexing the arm and adducting, bringing it closer to the midline. So pectoralis major. So in females, obviously there's a lot of fat and connective tissue that lies over that to form the breasts, but female bodybuilders, if you notice, ever watch female bodybuilding, there's very little breast tissue because the pectoralis major muscles are so well developed. And women that start to bodybuild will find they might even go down a bra size as that muscle uses up the fat for metabolism that lies over it. Okay, next we have the rectus abdominis, so that's what's shown here. These are muscles, cells that run vertically over the abdomen. They're covered by a thin sheet of that AVO neurosis here. So here's some AVO neurosis. Remember that connective tissue in a flattened sheet arrangement. But if we peel that away, we see this muscle, and this is what's called, what we see as the six-pack, right? If they're really well developed, they can bulge out, and you can see those connective tissue separations. So this is the rectus abdominis. So abdomen, you know, it's in the front, and rectus means it goes straight up and down. They're vertical fibers. Those muscle cells run vertically. So it flexes the vertebral column. So when the person does a sit-up, they're flexing the vertebral column. And it compresses the abdomen. So when a person coughs or laughs or exhales really hard, that's compressing the abdomen. So that's the rectus abdominis. So if a person's been, out laughing with friends all night, they'll wake up with kind of sore stomach muscles. Or if a person has a really bad cough, they'll wake up with sore stomach muscles from working that rectus abdominis. The external obliques come off the side here, so we can see these fibers here that come in at an angle. Those work the same, they do the same thing as the rectus abdominis, but when we add a twisting motion to a sit-up, we focus more on the focus more on the external obliques than the rectus abdominis. But as far as actions that you have to know, it's the same thing. Flexing the vertebral column as in doing a sit-up, or compressing the abdomen as in laughing or coughing. The transversus abdominis and the internal oblique are deeper muscles, so we have to peel away the rectus abdominis. So if we peel this away like it has here, I'll see that well, first of all, if I peel this layer, the external obliques, I'm going to see the internal obliques that are oriented at a different angle. So the external obliques angle down toward the midline. They're kind of in line with the inguinal region, pointing toward the midline, toward the lower half of the body, and the internal obliques are oriented the other way toward the upper portion of the body. So if I look at the angles, they're at right angles. It forms a right angle here when I combine the two fibers. But just know that the internal obliques are more deep. You have to peel away the external obliques. And then if I peel away those internal obliques, I'm going to see another set of fibers, and this is the transversus abdominis. So they run horizontally. Unlike the rectus abdominis that runs vertically, the transversus abdominis is horizontal, so that's the deepest of the abdominal muscles. And together, all these muscles make up what we call the core, right? And the job of these abdominal muscles, again, is to compress the abdomen, flex the vertebral column. So if they're really weak, these muscles are weak, it's hard on the lower back. The lower back muscles really have to work hard to keep the body upright. So it's important, especially in healthcare, that we work our core muscles and keep those strong. And that's not something that's really emphasized in healthcare. We talk a lot about the importance of using like a ceiling lift and using, portable lifts to get our patients in and out of bed or from the wheelchair to the toilet. We talk about the importance of using lift equipment, but what about those tiny movements, repetitive movements in nursing where you're reaching over the bed? Or you're reaching up to hang an IV, but oftentimes you're reaching over the bed to listen to heart and lungs, or reaching over the bed to hand a patient their call light, reaching over to hand them their water, to give them their pills, reaching over to do something with their IV. Those tiny little movements over a lifetime career can also damage the back. I've noticed that when I've worked a couple of long shifts in a row, my back really starts to bother me, and I didn't have to lift a single patient. But it's just because those tiny little movements. So the best thing a person can do to keep their back healthy is to work those abdominal muscles, do some strengthening. And it doesn't mean sit-ups. There's a lot of core muscle workouts that don't involve sit-ups because that can be hard on the back. But it's something to explore if you or someone has low back pain, chronic low back pain. All right, we're going to pick up with the arm, but let's take a short break before we do that, and we'll finish up the bottom half here. Okay, so looking at the lower, going from down the arms and legs, I guess, is where we're going to go next. So the biceps brachii is a muscle on the front of the arm. Biceps refers to the two heads that it has, where it connects to the bone, attaches to bone. So the biceps brachii. So it's important that you include that second name because we do have a biceps femoris in the leg. So the brachii tells us that region, right? Remember the brachial region is the upper arm. So the biceps brachii is when we're in anatomical position, it's kind of oriented toward the front. So, and when it contracts, it flexes the arm at the elbow. So flexing the arm at the elbow is the biceps brachii. And then the brachialis, the best way to find the brachialis, we have to actually do a side view of the arm. So the brachialis is a muscle that lies between the biceps brachii and the triceps brachii. So the brachialis is this muscle in between. Here's a better view. If you look at it with the palm side here, the brachialis is here. It's between the two muscles. You got the biceps brachii on the top, triceps brachii below, and brachialis in between. So if you look at your muscle models, or the pictures of the muscle models, that's the brachialis. Can you find that muscle down deep in between there? So together, the biceps brachii and the brachialis flex the arm at the elbow. So the triceps brachii is here. It's on the back of the arm. We don't often use a lot of effort to extend the arm at the elbow. So if we look at, this is the triceps brachii here. If we go back to this is the triceps brachii here on the back of the arm. So it has 3 heads that attach to bones. So that's where it gets that name. So triceps brachii is when you extend the arm at the elbow. So when you straighten out your arm, that's the triceps brachii. So again, we're working with gravity when we straighten our arm out. So the triceps brachii can be pretty flabby unless we're working it specifically. So that's why when grandma waves, she keeps on waving with that flabby back of her arm, right? And some women have really flabby, loose skin on the back of the triceps that you try to do a blood pressure and their skin is just like, you're trying to get it in the blood pressure cuff because it's all over the place. So sometimes we can't even do a blood pressure, especially in a very obese person. It's hard to get a blood pressure if they have a lot of loose skin there. So we tend to use the lower arm for blood pressures, or even the lower leg if we can't get a good blood pressure in the lower arm, or if there's IVs there. You can't put a blood pressure cuff there, so we have to go to the lower leg even. It's not ideal because the further we get from the heart, you know, we're not going to get as good of accurate pressures, but it's good enough to see trends in pressures. But it's important to work the triceps brachii if you want to have that toned back there and not be flabby in the back. So flexors of the wrist and hand. So if you think of your wrist and hand and put it in anatomical position, when I'm flexing, what muscles are shortening? The muscles on the palm side of the lower arm or the top of the hand side when I'm flexing? Again, think of what's shortening and pulling on that hand. It's on the palm side. Yeah, I can feel the stretch on the top of the hand side of the lower arm, feel that stretch there, but that's not what's working. What's working is the palm side. So if I look at this, here's the flexors of the wrist and hand. This is the palm side of the arm, so it's on this side are the flexor muscles. Now you don't need to know all the different flexor muscles, you just need to know them as a group. All you have to say is flexors of the wrist and hand. So again, if we're looking at the top of the hand, that's what's shown here. These are the extensors of the wrist and hand. So extensors is when you open up your palm and bring your wrist back. So if you do that, if you bring your wrist back and stretch out your fingers, you'll notice how much more difficult that is compared to flexing the wrist and bringing it inward, because we don't do that activity much. We tend to do a lot of writing and keeping our hands curled, and as a result of that, those muscles get kind of weak in the extension part, and that puts us at risk for carpal tunnel. If you have a job where you do a lot of typing and writing and closed hand activities, you can develop inflammation of the nerve on the inside of the wrist, the median nerve. So it's important to just stretch your fingers out and work those extensors a little bit to open up that nerve space. So the iliopsoas, now we're moving down to the bottom. The iliopsoas muscle is a muscle on the inside of the hip. I'm going to go down one here. Okay, so the iliopsoas muscle has 2 parts to it. So these are the 2 parts collectively you need to know as the iliopsoas. So it's deep in the groin. It can be problematic in runners, causing kind of groin pain if they don't work that muscle. So there's two parts to it, and these are the two that you need to know. Iliopsoas collectively. The P is silent in this word. So what is the role of the iliopsoas? Is to flex the hip. So it's when you bring your knee up, bend at the hip, that's working the iliopsoas muscle. And like I said, runners and wrestlers and people that do a lot of, bent hip activities have sometimes difficulty with the iliopsoas. So then if we look at the back side of the body, the gluteus maximus is one that everybody's familiar with. That's a common term that we use. That's the larger muscle of the buttocks. So that the job of that muscle is to extend the leg at the hip. So when you bring the leg backward behind the body, so kicking backward is extending the leg at the hip because you're increasing that angle at the hip. And flexing the leg at the hip, again, is bringing the knee upward. So this is the job of the gluteus maximus, is to extend the leg at the hip. So when a child starts to walk, they really start to develop those glute muscles compared to a child that's just crawling. So we need well-developed gluteus muscles, gluteus maximus, to walk and to run. And that extends the leg at the hip. And if we go back to the front, at the hip. So now we go to the front of the leg, back to this. We've got the muscles that make up collectively what we call the quadriceps muscles. Quad means how many? 4. You only have to know 3 of the 4 muscles that make up the quadriceps. So these are on the front of the thigh. And the one that runs right down the middle and connects to the kneecap via this tendon, this is called the rectus femoris. Rectus femoris. So we had the rectus abdominis in the abdomen, right? Now we've got the rectus femoris in the leg. And what major bone is underneath here? The femur. So that's where rectus femoris comes from. The femur is what it is down underneath. And this works with the gluteus and brings the leg back, as in when you're getting ready to kick a ball. So extending the leg at the knee. I'm sorry, that's the hip. I apologize. Rectus femoris is extending the leg at the knee. So when we kick our knee outward, when you kick a ball and you bend the knee and you kick straight out, when you straighten the leg, that's extending the leg at the knee. So when you sit in the machine, right, you put the weights on the front of your ankles and you push outward, that's the leg extension machine. And that can be really hard on people that have knee problems. So if you have knee problems, that is a weight machine you want to avoid. The best way to develop the rectus femoris for people with knee issues is to do kind of straight leg bends. So you're still extending the leg at the knee and then you're just lifting it against gravity. So that's a good way to develop that muscle. And the quadricep muscles I talked about before are important muscles for strengthening the knee and stabilizing it to prevent knee injuries in athletes. Then we have the vastus lateralis and the vastus medialis. So that second name tells us one is lateral, one is medial. So we're using the rectus femoris as our reference point and go down at the level of the knee. So this muscle on the inside is the vastus medialis. The muscle on the outside is the vastus lateralis. So these 3 muscles, and then there's a vastus intermedius, which is a little deeper, and that's the one you don't need to know. So that's the 4th muscle that makes up the quadriceps muscle. But you just need to know the vastus lateralis, vastus medialis, and then the rectus femoris in the middle. So those are the muscles over the front of the thigh. And then we have the sartorius, and the sartorius is easy to find because it connects on the outside of the hip, crosses over to the inside of the knee. And there's this connective tissue, this ligament here. So this is this long strap-like muscle that it comes over at an angle from the outside of the hip to the inside of the knee. And what that allows you to do is pick up your leg and cross it. So when a person crosses their legs, they're using that sartorius muscle. Some people call it the tailor's muscle because a tailor who used to adjust the hems on jackets and dresses would sit on a small stool, cross his leg, and then lean forward and adjust the hem of that jacket or dress. And that's why it's called the tailor's muscle, because that muscle is what's used to cross the leg over the other. Then we have the tensor fasciae lata. This runs along the outside of the leg. We can see it here, coming down and attaching to the outside. So here's the muscle itself way up here at the hip, but it has this long connective tissue sheet, and we call any connective tissue in the body is referred to as fascia. So a good way to remember it is there's a lot of fascia on the tensor fascia lata. Some people have heard of the iliotibial band syndrome, IT band syndrome. People that run can sometimes, or play, repetitive running sports, can get irritation of and shortening of this muscle. So it's important to do exercise that stretch this fascia, this tendon here. But the muscle itself is up here. So when we look at what the action of the tensor fascia lata, it abducts the thigh. So you're taking that leg and you're moving it away from the midline. So just straightening the leg but moving it to the side. So it's the tensor fascia lata. And then the gluteus medius, we go back up to the back side of the thigh or the leg here. That's not a great picture. We'll go back up to here. The gluteus medius is here. It's above the gluteus maximus. That's the gluteus medius. And then the biceps femoris is on the back side of the leg. So if you go down to the knee here, these can be a little tricky, but if you focus on the tendons and how they attach, you can kind of sort out these muscles on the back of the thigh. We call these the hamstrings, right? The muscles on the back of the thigh. So there's 3 muscles that you need to know. There's the biceps femoris, which is here. And if you feel the back of your knee, can you feel the tendons kind of tense up the muscle on the back of your leg? And can you feel those tendons pop out? There's a really thick one on the outside of the knee. That's what you're feeling here. That's the biceps femoris. Can you feel when you go on the inside of the knee, can you feel one tendon's kind of weak and the other one's really strong? Can you feel that difference between those 2 tendons there on the inside of the knee? Those are the 2 muscles we call the semitendinosus and the semimembranosus. The one that you can feel really well is the semitendinosus because it's got a strong, long tendon associated with it. The other one is a little flatter with a shorter connection to the bone. So if I look at it, here's the semitendinosus. It's kind of thin, has a long tendon. That's what you're feeling. So that's the semitendinosus, and the semimembranosus lies underneath it. So these muscles, it looks like 2 muscles here, but it's not. This is just a thin, flat muscle, not necessarily thin, but it's flatter and wider than the tendinosus. So the tendinosus is thin, the membranosus is wide. That's why it gets the name membrane. And it has a much shorter connective tissue connection here, tendon. So the membranosus is underneath. It's both of these underneath, and then the tendinosus is on top. So a way to remember that is semitendinosus on top, and then semimembranosus is underneath. And together, all 3 of these muscles, the biceps femoris and the 2 tendinosus muscles, flex the knee and extend the leg at the hip. So flexing the knee means you're kicking the leg backward at the knee. So you're bending the knee and putting the foot toward the buttocks. So that's the flexing the knee part. And extending the leg at the hip, again, is you're bringing the leg backward, as in if you're getting ready to kick a ball really hard. Then we have the adductor muscles. So these are found in the groin area. And this is what brings the legs together. So there's an adductor machine at the Y. You sit in and you put your legs in there. When you bring your legs together, that's the adductor muscles you're working. And when you adjust the setting and you're trying to spread the legs apart, that's the abductor muscles that are working. So the adductors we're going to find on the inside of the thigh. And while we're on the back side here, I'm going to skip over those for just a minute and go down to the gracilis, because the gracilis is a good reference point. So here's the gracilis. We're on the inside of the thigh. There's this long strap-like muscle that extends all the way down the inside of the thigh, and it's called the gracilis. And again, to adduct our leg at the thigh takes no effort. We just bring our leg out and just drop it to the center. So this muscle is pretty weak, and especially in women. Women tend to have flabbier thighs because estrogen controls where fat deposits, and we tend to deposit fat on the butt and thighs. But the inside of the thigh is particularly flabby because we don't work that muscle adducting the leg. So the way to develop it then is to get in a machine to, or use just exercises at home to specifically work that muscle. So the gracilis adducts the thigh. And then, so on the back side is the adductor magnus. So here's the gracilis, here's the adductor magnus. So the magnus is on the back side of the thigh, right next to the gracilis, below the gluteus maximus, adductor magnus. And it's much bigger, thicker, wider than the adductor longus, which we have to find on the inside. So the adductor longus, if we look at this front view, up at the, is the gracilis here is this long strap-like muscle. And then the adductor longus is right here on the other side of the gracilis. So if we're on the front view, it's the longus. So adductor longus, gracilis, and on the other side is the adductor magnus. So they're all right next to one another on the inside of the thigh at the groin is where they connect. So longus, gracilis, and magnus on the other side. All working together to bring the legs together. Then we go to the bottom of the leg. Here's just some nice views, different views showing these muscles. So you've got the three quadricep muscles, vastus. You have to look at where the foot is. This is the big toe here. This looks like the left leg. So this would be the vastus medialis, vastus lateralis, rectus femoris, sartorius, gracilis, tensor fascia lata. Here's the inside of the leg. Here's the gracilis again. So you've got the adductor magnus and the adductor longus. See how much longer it is compared to the magnus, which is a little thicker and fatter. So this is the gracilis. Again, you're using that as your reference point. Okay, so now we'll move down to the lower leg. So let's look at the back of the leg first. This is the calf muscle, which we call the gastrocnemius. Has a very long tendon, strong tendon attaches to the back of the heel, and this is the Achilles tendon, right? So the gastrocnemius is this large muscular organ. Runners, especially middle-aged runners that overdo it, they've got a great heart and lungs, they've got strong muscles, so they're going the extra mile, they're participating in ultra marathons and running long distances, but what happens over time as we age, our connective tissues can no longer keep up, they become more brittle, they tend to break down, and we see a lot of injuries with the Achilles tendon in people that do long distance running, or even people that are football players, you know, that are putting a lot of pressure. You have to gain a lot of weight to play college level football, even high school for that matter. That can be too much for this Achilles tendon to support, and people can have damage and tears to the Achilles tendon. Then if we remove well, let's look on the front of the leg. So here's the front of the leg. We have the muscle over the front that allows you to bring your toe to your nose. So when you bring your toes off the ground, you're looking at the tibialis anterior. So that's on the front of the leg, and that brings the toe upward. I'm trying to get to it here. So the tibialis anterior here. So when that starts to tear away, some of these muscles on the front of the shin start to tear away from the bone, again, with too much activity, we end up with something called shin splints. And if you've ever had shin splints, they're just miserable, right? The inside of your leg just really aches, and it causes a lot of pain and inflammation because the connective tissue fibers that attach these muscles to the shin bone start to tear away with excess activity. And as a result, you get shin splints. So the best way to toughen up our connective tissues is to gradually get into activity and not overdo it. So we have to just be kind to our connective tissues and not start pounding with excess activity before the connective tissues have toughened up. And I've struggled with some of this stuff myself. I like to do some running, and if I go too fast, too hard, I get injured. So I have to be very patient with myself. And then you can get there, but you have to be patient and slow as these connective tissues adapt. And sometimes some of you may be into coaching one day, or maybe you are already. And cross-country teams, if you look at those kids, some of them sit around all summer. They go out for cross-country, like starting in middle school and high school. And then by October, 3/4 of the team has shin splints and is miserable. And oftentimes it's because of just increasing that running from sitting around to, running every day, 2 to 5 miles, it gets to be too much. So doing some strengthening exercise is important, like just calf raises is a really good way to strengthen up the muscles, the gastroc. And then doing some, lifting up of the toes off the floor. That helps strengthen the tibialis anterior. And then if we peel away the gastroc, there's a muscle underneath it which also needs to be stretched. It's the soleus. So underneath the Achilles is the soleus muscle, and that can be damaged too with excess running. So when a person stretches after running, we do a straight leg stretch to stretch the calf muscle, right? But if you want to stretch the soleus, you have to bend the knee and push the heel down, and you'll feel that stretch convert to the lower part of the leg, and that is important to stretch as well. We tend to only stretch the gastroc and we forget about the soleus, so got to bend that knee. Both of those work together to plantar flex the foot. So plantar is the bottom of the foot, right? So when we point our toes downward, that's plantar flexing. When we bring our toes to our nose to work the tibialis anterior, that's dorsiflexing. So what do you tell someone when they scream out in the middle of the night, oh my gosh, I have a cramp in my leg and my toes are pointed downward, my calf muscle is cramping? And this happens to people that are on their feet a lot, people that they're a little low in potassium, they get these cramps. And during pregnancy with some of my kids, I would get cramps. I would kind of stretch in the morning and I'd point my toes and all of a sudden I'd be stuck in the pointed position and it would hurt. What do you do to, help a cramping muscle? You oppose the flexion, right? You want to stretch it in the opposite direction. So what would you tell that person to do? If their toes are pointing downward, they're plantar flexing with a cramp in the calf muscle. What did you say, Alicia?
Just peel that.
Yeah. Tell them, put your toes to your nose. And they can do that. Even though it's cramped, they just have to fight it a little bit more. But bring the toes to the nose, right? Bring the toes upward, and that'll work out that cramp. So again, make sure you know the actions of these muscles and know the terms. Adduct, abduct, dorsiflex, which is bringing the toes to the nose. Plantar flex is pointing the toes. Know those terms and what they mean. So when you have to choose on the lab exam, the multiple choice options, you know what those terms mean.